Deputy, that in light of who we represent, that change hasn't occurred. But that vest wearing is optional by anyone employed by the state police. Are you aware of that?
And again, I'm not going to argue facts with you. I don't know, but as my understanding is that if you're out on the, if you're out a police officer on the street, you have to wear the vest.
And it's your understanding that your vest policy for H-1 members is to be proactive in ensuring their safety, correct?
I believe so.
So why isn't it the policy of the DOC to make everyone who has contact with an inmate, regardless of the level or who they are, to wear a vest?
And again, I'm in a position I can't answer that. As a deputy, I think that's more suited for the Secretary of Corrections. He's the one who makes the policies for the Department of Corrections, not I.
Very well.
Thank you, gentlemen. Appreciate the testimony.
Thank you.
Thank you.
Take a short break so we can gin up our next presentation.
Okay, let's take 5 minutes. All right, we're back on the record and ready for the Commonwealth's next witness.
The Commonwealth presents Tara Long, Chief, Insurance Division, for our healthcare presentation.
Good morning, welcome.
Thank you. This on?
What?
I broke it. I said, is it on?
It's not.
Okay. Figures I start off breaking stuff. So I understand I stand between the panel and the participants and lunch, so I promised that I would make this quick for them because I know how important food is for everybody. My name is Tara Long, and I work for the Group Insurance Division in the Office of Administration. I've been with the Office of Administration since 2000, so almost 11 years now. Right now, I'm the Chief of the Group Insurance Division, and in that capacity, I oversee our group insurance program, which includes our health program, life insurance. It also includes our Pscoa program, our State Employees Combined Appeal program, and also we administer our state police benefits. Our first slide shows a slide that you may have seen before in other presentations, but it talks about the healthcare cost pressures that the United States has really seen over the last 12 years. And you can see the changes between and the comparison between premium increases within healthcare, which is the red line at the top, and CPI and wages. And it's a pretty common fact, and everybody understands that healthcare has and continues to outgrow every other major indicator in the United States. We also wanted to look at where those premiums are going and what the cost share is for those premiums. And so we looked at family versus single coverage for basically the same time period. And what you can see on the top line is that average premiums for family insurance have been running around 30%. It's slightly increased over that time period. And right now, the average is about $3,997 that employees are paying for family coverage. When you look at single coverage, it's slightly less, starting at 14% and rising up to 19%. And for single coverage, employees in general are paying about $900 per year. We also then added in the PVTS data for state employees over that same time period. And what we did in looking at this was take the annual expenditures and the annual employee contributions, and we came up with 7.36% as of last year. And that roughly equates to about $1,008. So for the average state employee, you can see over that time period that they're paying less than they would at the national level. In addition to all of the things that we see about healthcare increases in costs, we talk about trends in new technology, the latest and greatest in terms of treating members. There's also been legislative changes that have increased in costs for employers and for health and welfare funds. And one of those, and probably the most talked about in the last year, has been the Patient Protection and Affordable Care Act of 2010. We call it PPACA. And I just wanted to note some of the benefit enhancements that have been implemented for these members. For dependent coverage, it's been added up to age 26. That went into effect January 1st of 2011. I did want to note that the board members of the PBTF decided that any dependent who was eligible for this and enrolled as of May 1st was allowed to stay on. They didn't think that it was fair that someone who turned at that point 23 in May would lose coverage only to become eligible again in January. So they made a decision to implement that slightly earlier and leave them on. We've also eliminated the out-of-network maximum for the PPO and the consumer-driven health plan. The trustees also decided to cover flu shots through the benefit. Previously, it had been provided to employees through a joint venture with the Commonwealth. Effective July 1st, it will be offered for employees and their dependents, and that's being offered earlier than required. Those three programs will cost the PBTF an estimated $15.2 million extra each year. The largest percentage of that is coming from the dependents to 26. In 2014, I know that the union has requested to cover preventive screenings earlier than what is required under PPACA. And so Aon Consulting, who is the consultant for the PBTF and also for Mr. Einhorn's trust, I think he testified to that a couple weeks ago, went through and figured out what the PBTF would need to add to their preventive screenings to come in line with PPACA. And so this just shows the tests that are there. You can see a lot of coverage for things like STDs, pneumonia, and meningitis. The annual exams for children is just adding additional exams under what's already required. And the annual cost for that is about $5.3 million. The largest expense under that program is going to be shingles. The shingles vaccine is very expensive, and so that's where we think most of that cost is going to be coming from. So those are just showing you two areas where we see the increased cost to the PBTF as a result of legislative changes. I just wanted to briefly talk about the PBTF. I know we talk about it every time we do presentations, but it was created in 1988, so it's been around for a long time. It is a joint labor and management trust fund, and it administers benefits to about 141,000 active and retirees. The active plan does include management and union employees, and when you include the dependents, it takes us about 287,000, which makes it the largest employer-sponsored health plan in Pennsylvania. The board is run by 18 trustees. There are 9 appointed by the unions and 9 appointed by the management. The PBTF does have the sole discretion to determine the extent and the level of benefits, and that is in accordance with the trust agreement and the various parties' collective bargaining agreement. And I won't read it to you on the next slide. It does just quote the PSCOA's collective bargaining agreement that gives the trustees the right to determine the level of benefits. I did talk about the union side and the union membership in the PBTF, and it is a large component. There are 70,000 employees in the PBTF that are represented by various unions, and they're listed there. And you can see that there are 18 unions that participate in the PBTF, and they range from 20 to 41,000 members. And you can see on there that PSCOA is the second largest, and they have 11,200 members. I do want to note that this is eligible members. Some employees do decide to decline benefits, but they are eligible, so these numbers look a little different than some other things that you may see. This pie chart just goes to show for the union trustees where and what percentage of employees they represent. AFSCME does represent about 58% of the union covered employees, and they do have 4 trustees. You can see PSCOA is the next largest at 15.85%, and they have 1 trustee. And then it goes down, you can see PSSU, SEIU, UFCW. PSEA I have as an asterisk under the trust agreement. The one union is elected to represent those smaller units. We wouldn't have a union trustee for a 20-member union. So PSEA represents all of those unions. We're going to go through and we're going to talk about the PBTF benefits. We do offer medical benefits. We have a PPO, HMO, and consumer-driven health plan that's offered in every county. Our supplemental benefits package includes prescription drugs, dental, vision, hearing aid, mental health, and substance abuse. The PPO is the most popular plan. We actually have about 62% of our membership that's in the PPO, but they do have the choice of the HMO or the consumer-driven health plan. When we start talking about the medical benefits, I wanted to clarify, we took a different approach to presenting this information, that we wanted to show you a side-by-side comparison of really what the PBTF offers and what the PSCOA is proposing. For medical benefits, PSCOA hasn't proposed a change to the deductibles or the co-payments. And you can see that the PBTF continues to offer a rich benefit when compared to other employers. I started looking at some of the different studies that are out there, and you can find any study. I looked at Kaiser, which is usually considered kind of the standard, and I thought it was interesting that 66% of employers now have a deductible and the PBTF doesn't. Office visit copays are $22 for a primary care physician and $31 for a specialist. PBTF is lower than that. And most employers have an additional hospital copayment. So every time you're hospitalized, you would have another out-of-pocket expense. PBTF has none. And the emergency room copay, which I thought was really interesting, averages $109. And the PBTF is $50. And if you're admitted, that's even waived. On the prescription benefits, this is a chart that's busy, so I apologize. But really, for the prescription co-payments, on the first 3 rows, we're looking at the same thing. What PBTF offers and what the union has proposed are the same, with no co-payment changes. Where you see a difference is on line 4, where the union has requested to provide prescription drug coverage at generic copay levels for over-the-counter proton pump inhibitors and non-sedating antihistamines when they're prescribed by a physician. So we used Rite Aid. Rite Aid is the pharmacy that the PBTF allows you to get a 90-day supply. So we've just looked on the Rite Aid website, and we found that right now an employee can go in and they can buy Pepsid, and it would cost them $23 out of pocket. Under the union's proposal, since that is a 90-day supply, the 90-day co-payment would apply, and they would be charged $20. For allergy over-the-counter medications, the employee can purchase the generic for Claritin at $25, but that's a 120-day supply. Under our program right now, we don't allow a 120-day supply at retail, but if we would apply the 90-day supply and the 30-day copay, and so the employee's out-of-pocket expense would be $30. And again, we used Rite Aid as a standard for that. Employees could have the option to go and look at other places, and they may be able to find some differences. When we looked at the dental benefits, this is where we do see a difference in what the PBTF offers versus what PSCOA is presenting. They've requested to increase the annual maximum to $1,500, and they've requested to increase the orthodontic maximum from $1,250 to $1,500. The combined 4-year cost for increasing those 2 benefits is about $4.9 million for this unit alone. The union has also requested to have the Delta Dental network of providers, and I know when they presented their case, they had agreed to provide a provider analysis, a disruption analysis to look at that. But we went out and looked at it for the PBTF. For UCCI, right now the provider access, and the standard is 2 providers within 10 miles, and UCCI has a 96.9% access rate. If I just look for one dentist within 10 miles, I actually get to 98.8%. Under the specialists, I have a 97.3%, and that was the same for UCCI and Delta Dental. I looked at some of the areas where we didn't have participating dentists, and to be honest, I didn't know the names of the cities, and I had to call somebody and say, what's near here? And so, for example, I found 2 cities up near Rockview, one of the prisons. And I just did a Google access using those cities, and I found that there are no dentists. It's 23 miles, according to Google, till you find any dentist. So it's not that there's no dentist, there's not a dentist in the area that refused to participate, they just don't live there. It's a very rural area, it seems to me, according to Google, to be surrounded by a lot of state parks. So, looking at these numbers, we think that the UCCI provider access is adequate and is good for our members.